pressure as we examine these veins while we are coapting that vessel on our way down the extremity. The second thing we do to evaluate for clotting is to look at the flow patterns within the veins. We are looking for certain types of flow signals that indicate that your vessels are open. Some flow signals can indicate that there may be clotting either above or below the area of concern, which is why your ultrasound technologists are listening for these blood flow patterns. So it's nothing to worry about when you hear noises during your ultrasound. These are noisy tests. Typically, the ultrasounds are not very uncomfortable. However, in the case of an acute phlebitis, you may experience some discomfort when the sonographer is examining the specific spot of concern. As mentioned before, part of that coaptation process that we are assessing for means that we're going to have to apply a little bit of pressure to that site of concern. And that's pretty much it for ultrasound. Once we finish the test, those images are available for our providers to review. And if you are visiting a vascular clinic, typically you'll receive results immediately after we are complete. I just want to thank you.
Alyssa and Debbie, thank you so much for that enlightening description. I do have a couple of questions for both of you. You know, Debbie, are there treatments that the vein center can offer once the superficial thrombosis has calmed down? And what do you think we should suggest to our patients?
Absolutely. So it kind of depends what is the cause of the vessel. So if you have venous insufficiency where your valves are not working like we talked about, we can do procedures such as ablation to kind of burn the main vein. And then we can also do phlebectomy to remove the vessels that are, you know, bothersome and kind of bulge out and bother you. There's also other treatment options such as sclerotherapy. We can do it both regularly, where we would just do the ones that you see on the surface of the skin, or ones that are underneath the skin that you can't see. We can inject them, and it's almost with like a soapy, foamy solution that sticks to the vein walls and clots them off, essentially causing another type of phlebitis. But over your time, your body absorbs those vessels so they're not bothersome anymore. With that said, veins are weeds, so they can regenerate over time. So the greater saphenous or small saphenous vein are not going to come back, but those small vessels can regrow over time. And, you know, that's kind of why I love veins so much, because they're very different and interesting. So I love to teach patients about them.
That's awesome. Thank you. And Alyssa, some people get a little lightheaded. What are some maneuvers that you can do to help patients get through some of these tests in a dark room when they're a little scared and when they may have pain in their leg?
So two of the most important things to keep in mind is that you don't want to be holding your breath. So ideally, the sonographer will remind you to breathe normally, to, take deep breaths in, blow it all out. Try not to hold your body very tense while you're being examined, because both of those things are going to increase the likelihood that you experience some discomfort. One other thing to keep in mind is that there is a small subset of patients who experience something akin to seasickness when they look at the ultrasound screen while the image is moving. So if you feel as though you are someone who is sensitive to that sort of motion, don't watch the screen while your technologist is scanning.
Yes, and if you just communicate that you're feeling that way, your nurses can get involved. We can give you like cool compresses on your head and try to make you comfortable and do some position changes.
Absolutely.
So there is a question from the audience. The question is, can these superficial clots come back?
They can. Technically, it's if we've treated the vein and it's taken care of, it's gone. But not saying that over time it couldn't come back and it couldn't happen again. So that is why you want to use those preventative measures that we talked about to try to avoid getting blood clots. So wear your compression socks. If this is a recurrent problem, definitely want to talk to your provider about it. You may need to see a hematologist to get your blood levels checked to see if you have some type of clotting factor going on.
Thank you for that. Yeah, you know, we see a lot of patients with phlebitis, and sometimes it's because they ran into something, but sometimes it can just happen spontaneously. And as we know, you know, there can be recurrence because once a vein has clotted, it's diseased in that area and it can scar. With that said, just because you have a phlebitis definitely does not mean you must have a procedure, not at all. In fact, there's a lot of people that are very comfortable just using their compression stockings and don't want or need anything done. That's really a patient-driven issue, if you will. I would love to turn next to Dr. Raible, who's one of my partners, and it is an honor to have him talk a little bit about deep venous disease and thrombosis specifically. Dr. Raible, you're welcome to share your screen.
Thank you. Hold on. Let me figure out how to do that.
In the meantime, there is some question from the audience saying that if those clots are coming back, what they can do regarding about that, Kathleen?
Yes, so we can do, as Debbie mentioned, we can do phlebectomy where we can remove the vein. I don't usually like to do that in the early acute period because the vein will get very inflamed and can be kind of sticky. So we usually wait for it to kind of calm down before we intervene, but we can definitely do phlebectomy, another option. It depends on the size of the vein, but sometimes we can make a small nick in the vein itself and squeeze the clot out. Sometimes that will relieve some of the discomfort that people have, but overall, for a superficial phlebitis, warm compresses, a non-steroidal anti-inflammatory, and time will make it feel better.
In the meantime, they would like to know what are the way that if you use anticoagulation for long term with those patients and in the people who has recurrent phlebitis.
Yeah, so again, there's a difference between superficial phlebitis and deep phlebitis or thrombosis, which Dr. Raible will discuss. So for superficial phlebitis, generally speaking, we don't use anticoagulation long-term unless there's a reason. So pulmonary embolism, something else. But again, I don't want to take away from Dr. Raible's discussion, but for superficial phlebitis, generally most patients do not require anticoagulation. In those patients where we're concerned, sometimes an antiplatelet agent such as aspirin or Plavix can be helpful. But I think the more important point is that if somebody has continued recurrent phlebitis, there might be an underlying problem that should be known or addressed. With that said, I'd love to turn now to Dr. Raible. Dr. Raible, thank you so much for joining us.
Thank you for having me. Can you see my screen?
Yes.
Okay, great. So I'm going to talk about deep venous thrombosis, DVT, or more commonly known as blood clots. Just some brief anatomy. Debbie talked about this a little bit, but arteries are the blood vessels that bring blood from your heart to all your vital organs, to your fingers and toes. And veins are the blood vessels that return all that blood back to your heart. In the leg in particular, where DVTs are most common, here's just a picture of the main deep veins within the leg, all the way up into the pelvis and the abdomen. And then just a little cartoon of the difference between a deep vein, which is constrained within your muscles, deep within your leg or arm, versus the superficial veins, which are in the fatty tissues above the muscles. And then even above superficial veins, you have your sort of spider veins you may see, or varicose veins. So what is a DVT? A DVT is a clot or a thrombus that forms within a deep vein, again, commonly in the leg. And what happens is your red blood cells, platelets, and other proteins within the blood start to stick to a deep vein, and then more blood and platelets and proteins stick to that blood that's already stuck, and it forms this large sort of, glob or blob of blood products, which is the clot or thrombus. If that thrombus breaks off and travels, such as the top part of this picture here, that's called an embolus. That's a blood clot that could travel to, say, your lung, where you can get something called a pulmonary embolus, or PE. We're mostly going to focus on the DVT, or the blood clot that occurs in the leg, though. Symptoms of DVT are not dissimilar to superficial phlebitis. You get leg swelling, you get pain and tenderness, and you get some discoloration. Usually the pain and tenderness is more deep within the leg, as opposed to just under the surface of the skin. So you don't often get a brighter, redder area along a superficial vein. You kind of get a general discoloration of, say, the calf or the thigh if it's an extensive clot. And it's more of a deep pain or ache or tenderness, and kind of a global swelling of the leg, as opposed to a localized swelling. So that's some of the things that we as clinicians use to sort of determine, before we do testing, whether this may be a DVT versus a superficial clot. So what causes DVT? This slide's busy, but there's three kind of key points, and any one of these three can put you at risk to develop a DVT. Certainly, if you have more than one of these going on, your risk for DVT starts to go up. So hypercoagulability means anything that predisposes you or is going on with you to cause your blood to want to clot. So this can happen after major surgery, or accidents or trauma, in the setting of cancer, during pregnancy and thereafter, for a period of time. It can be inherited things, sepsis and infection. And then some other common things, estrogen therapy can increase your risk for a blood clot. Any sort of inflammatory state, so injury to a leg or extremity, or anything else going on causing inflammation. And then dehydration, as Debbie said earlier, puts you at risk for a clotting. Vascular damage means injury to the blood vessel itself. So this can be things like an IV catheter in an arm, or again, trauma to a leg, or trauma related to surgery, such as after like a knee or a hip replacement. And then the last part of this is circulatory stasis, or meaning the blood is not flowing fast enough and the blood wants to start sticking. This can happen because you're immobile, whether it be you're sedentary, or that you're immobile because you just had you broke your leg, or had a hip replacement, something along those lines. Different cancers, pregnancy, things like that can impede the drainage of blood through the veins. varicose veins can contribute. And then other things like heart defects or congenital abnormalities can all cause the blood to flow more slowly, putting you at risk for clotting. Sorry, wrong way. So diagnosis of DVT almost always starts with an ultrasound. And Alyssa told you about that. There's some technical differences for how an ultrasound for DVT is done versus superficial phlebitis, but by and far it's going to feel the same, look the same, sound the same to you as a patient. Sometimes we'll also do something called a CAT scan or CT scan, where you get some dye injected through an IV catheter, and this helps show us kind of the larger veins that are within your body, in the pelvic area or in the abdomen. If it's an extensive blood clot, a CAT scan may help. So medical treatment of DVT, this is first line always. Everybody who has a DVT gets treated with medicine and other maneuvers, and I'll talk about surgery in a minute, but anticoagulation or a blood thinner is essentially mandatory if you're diagnosed with a blood clot. There's a whole bunch of different blood thinners on the market, so I'm not going to go into the details between them all, but you know, your vascular provider or clinician should be able to choose one that's appropriate for you if you're diagnosed with a DVT. Compression, meaning either a compression stocking or things like an ACE bandage wrapping of the leg to provide some squeeze to reduce the swelling, is important. And then elevating the leg as much as possible. You don't have to be sedentary. There's no activity restriction if you have a DVT per se. But if you are going to be not doing anything, it's best to have your leg up above the level of your heart. This helps the blood that is not clotted drain back to your heart, which will help reduce the swelling. And then finally, I'll just talk briefly about surgical treatment. As a vascular surgeon, you know, this is what we're often called to evaluate a patient for who has a blood clot. So these are just a bunch of different tools at our disposal. There's different systems we have to remove the blood clot physically by pulling it out of a vein. There's other tools that help infuse medication to dissolve the DVT. And then sometimes we'll do things like stents if we find an abnormality that triggered the DVT that may be treated with something like a stent. But these are just a few tools in our toolbox for the surgical treatment of DVT. You know, it's kind of customized to each patient and where their DVT is. One thing I will say, and I'll go back to the anatomy slide quick, we often reserve treatment, surgical treatment of DVT to blood clots that extend from the very top of your leg, from the common femoral vein up into the pelvis and abdomen. We don't always or rarely treat blood clots with surgery if it's in your thigh or calf. Medicine alone is sufficient for that. Questions?
That was an excellent presentation. Thank you so much for sharing. I love this last slide here. Do you mind pointing out to everybody who's online where the blood clot is in that intravascular ultrasound, and just say a word or two about that?
Sure. Yeah, you can see my pointer.
Yes.
Okay. So this bottom left picture here is a picture of ultrasound that we can do inside the vein itself. We have a very small ultrasound catheter. It looks similar to this device over here that we feed through the vein itself, and it shows us an ultrasound from inside the vein. So this screen on the right is what a normal vein looks like without a blood clot. The black is blood that is flowing without a clot. On the left here, you can see this bright white within the black circle. That's blood clot. So when we do a surgical procedure, we'll often do an ultrasound within the vein to better localize where the blood clot is, and also look for any underlying problems with the vein that we need to address.
Thank you for that. So there's a lot of questions that have come up on the chats that I'll ask you guys. So there's a question from Buenos Aires. Welcome to the webinar. How far from the saphenofemoral junction is it safe not to anticoagulate? Dr. Raible, I'm going to throw that one at you.
I imagine we're talking about a superficial phlebitis in this question. Usually if the clot is at least 2 centimeters or more from the saphenofemoral junction, it's safe not to anticoagulate. Some providers will start an antiplatelet if it's in the great saphenous vein in the thigh. But usually if it's more than 2 centimeters, a full anticoagulant or blood thinner is not necessary. And that's something we monitor with ultrasound to make sure it hasn't progressed.
Yeah, because some of the treatments we have for a superficial venous disease can sometimes lead to a clot forming near that junction between the superficial and deep system. But that in and of itself is not, it needs to be monitored, as Dr. Raible just pointed out. If somebody comes in, and I've seen this where somebody never had any procedure done, and they come in and they say, there's this bright red painful line that's literally traveling up my leg. Those are the patients that, you know, I will certainly recommend once it gets close to that saphenofemoral junction. That's when we start to worry about it potentially extending into the deep system. And there's a couple of options. I mean, one is to surgically ligate it. So we make an incision in the groin and ligate that, or tie off the vein that leads into the deep vein for protection. And the other, of course, more commonly is just blood thinners. So yeah, I think again, for the question from Buenos Aires, I think it depends on what also the patient has had done. Is it spontaneous and came out of the blue, or was it after a procedure as well? So another question, do some patients get superficial and deep clots? And how does this change detection? So Alyssa, I'm going to ask you to answer the detection part of that.
So from an ultrasound standpoint, it does not change much, because typically we are evaluating the deep system and the superficial system every time we do an ultrasound. So we're utilizing the same technology and the same process to detect both deep and superficial clots. One thing I will say is that there are certain cases where there are superficial tributaries or varicosities that are perhaps on the lateral or posterior aspect of the leg, where we typically are not tracking the deep system with ultrasound. And it can be helpful if those areas of concern are pointed out to the technologist and clinician so that we are aware of them.
Would you also mind commenting on the difference between what an acute blood clot looks like in a vein on ultrasound versus one that is a lot of times labeled as chronic, and what's the difference between that?
So there are a few different characteristics that we utilize with ultrasound to help us age a blood clot. One of those things is the overall color of the clot. So ultrasound presents to us as a series of gray tones of varying depths. Often more acute or fresher clots show up closer to the black color or very, very dark gray. Aging clots tend to brighten up and move more toward the light gray and white end of the spectrum. Another big sonographic clue that differentiates between chronic and acute clots is, again, when we were talking about that coaptability before, a vein that has a clot in it will not be coaptable. We will not be able to squish those vessel walls together. But as clots become more chronic, they become a little bit squishier. We are able to deform and move some of those vessel walls closer to each other, whereas more acute thrombus will dilate the vein and make it so that we are not able to compress that material at all.
Would you also, there was another question about temperature of the gel. How does that affect scanning?
So the temperature of the gel itself does not impact the results of the ultrasound in any way. We just hope everyone has warm gel for patient comfort, because freezing cold gel isn't always the most comfortable thing to experience.
Thank you for that. Debbie, this is a question for you. Can you tell us a little bit about vascular lab accreditation or even vein center accreditation, and how that works sort of together to ensure that the studies that are being generated are correct?
Absolutely. So from a vascular lab standpoint, we have to submit so many studies to prove that our lab is doing it the correct way. And same for vein center. So vein center, there's a series of things that we have to go through the accrediting body to prove that our center is doing the correct thing. So they review our patient case studies. They can do randomized picks and pick any patient that they want to pick to look at. And each site, so we have multiple sites, each site has to have so many labs and studies done to prove that that site can be accredited and that we're doing the appropriate things.
Thank you for that.
Dr.
Raible, what anticoagulants are used most commonly for DVT? And in your experience, how long do you treat patients?
Sure. So it depends a little bit on what country you're in, but in the States, if you have a first-time blood clot and it's considered provoked, and I didn't get into this before, but if it's a provoked DVT, meaning you just had a knee replacement and you're a bit sedentary and you have a blood clot in your leg, that's considered a provoked DVT, and that would be treated for typically 3 months. Unprovoked DVTs are a little bit more worrisome. They're ones that you get for not a good reason, or something else is determined that predisposes you for blood clots. So the duration is at least 3 months, but sometimes longer if there's some underlying worrying factors. In terms of what medication is used, commonly Pixaban, which is Eliquis, or rivaroxaban, which is Xarelto, are used these days because they don't require any frequent monitoring. You can take them at the dose prescribed and you get full effect in terms of anticoagulation. other medications that may be used. Lovenox is an injectable medication. It's very, very good. It's very safe, very effective, but it's an injectable. And then historically, warfarin or Coumadin was used and is still used in some circumstances, but that requires frequent blood draws to monitor the levels, and it's affected by things like diet and other medications. So it's kind of fallen out of vogue, but it's still a very good medication.
Thank you very much for that. So another question for our speakers: can you have a DVT without pain and swelling?
You can. You can have a DVT that's a silent entity that you don't even know that you have. It all depends on, you know, what happened. Is it provoked? Is it not provoked, like Dr. Raible had said? But absolutely.
I think the other comment to that also would be that sometimes patients will go and they'll get a study done, and the report will say chronic DVT. And that's like actually a pet peeve of mine, because there's no such things truly as a chronic DVT. It's changes in the blood vessel consistent with once having had a DVT. So I guess it's not unusual that someone will get a scan that's had a history of a DVT, and then the report says chronic DVT, but really all it is just scar tissue. And that of course, it is not associated with pain at all. Here's another question, Dr. Raible. My mom has a DVT. Can I have it as a heritable trait?
So it's possible. Family history is definitely one of the things we inquire about when somebody's first diagnosed with a DVT. There's, a number of congenital conditions that predispose you to having DVTs, but most DVTs, are not necessarily from one of those conditions. So if your mother had, a provoked DVT and had a good reason to have had a DVT, then, that doesn't necessarily strongly indicate you're at risk for DVT. We didn't touch on this yet, but oftentimes we'll refer patients who develop DVTs to another type of specialist called hematologists. And they tend to delve deeper into all these congenital conditions. They can do a bunch of different blood tests to look for these conditions. So, that may be something that your mother should undergo.
And just to kind of piggyback off of that, if you do go to a hematology to get those blood tests, they take a little bit from the results to come back. So don't freak out if they're not back within a few days, because usually it takes several weeks for your hematologist to get them back.
Thank you. Debbie, I usually travel by plane. How can I avoid DVT after a flight?
Absolutely. So during your flight, we would recommend you wear your compression socks. If you can get up and walk on the plane, that would be great, just to kind of get your legs pumping. Because remember, your muscles, as they contract, that's what pumps your blood in your calves. So if you can get up and walk around, same thing when you're off the flight. Wear your compression stockings during the day when you're up and about, and then just at nighttime you can take them off and relax. But moving is the biggest, helper to help prevent that.
I also think, from speaking personally, when I travel, trying to stay hydrated. On one hand, if you drink too much, you always have to run to the bathroom, and that's always uncomfortable on a plane. But, you just be that person who says, excuse me, I got to get out. I got to go to the bathroom. It's okay. It gets you up and moving. And, as long as you continue to drink, that's extremely important. So Alyssa, this question's for you. How painful is ultrasonography?
So typically it is not very painful at all. However, if you are experiencing a particularly high degree of pain, swelling, or discomfort in your leg, you may feel a little bit of discomfort when the technologist is doing the compression maneuvers to evaluate the veins for blood clots. As mentioned before, some of the things that can increase the patient's comfort during the study is to make sure that you are breathing regularly. So take a full breath in and breathe all the way out. If you hold your body very tense and are holding your breath because you're like guarding in preparation for pain or discomfort, you are paradoxically going to make the test more uncomfortable for yourself, because when you tense your muscles and hold your body very stiff, it is much harder for the sonographer to do the slight pushing compression maneuvers to evaluate those veins.
Thank you for that. Dr. Raible, if somebody is already on long-term anticoagulation, say for atrial fibrillation, and they suddenly are found to have an acute DVT, what do you do?
So if it's an acute DVT and they're already on anticoagulation, there's a few things to consider. One is, where is the DVT? If it's, in the mid-thigh or down towards the foot, again, there's no need for surgery. If it's a more extensive DVT extending up into the pelvis or abdomen, surgery may be appropriate. And that may be a patient who should have a IVC filter put in, or a filter that goes in the main vein in your abdomen that would prevent a blood clot from traveling to your lung. Because if you develop the blood clot wall on a blood thinner, that is concerning. The other thing to consider is, are you on the right blood thinner? If you're on something like Coumadin and your levels aren't high enough, that may just mean you need a different dose. If you're on one of these newer medications, there are different doses that need to be adjusted based on other risk factors you may have. Or if you're on one of these newer medicines and you develop a blood clot, you may need a more traditional medicine that's tried and true. So these cases, we almost always get a hematologist involved to help kind of steer which medicine is best for a patient.
Another question along these same lines: if somebody gets a venous stent for what we call May-Thurner syndrome, where the left iliac vein is compressed by the overlying artery, how often do those stents become thrombosed or develop a DVT in the stent?
So a properly sized stent and placed stent in May-Thurner syndrome is very durable. It's important to monitor these stents with ultrasound, which we do in our practice. We follow these stents lifelong, with ultrasound to make sure they're not starting to collapse or fill up with blood clot. In terms of a rate, I don't know off the top of my head, 10% or less probably rethrombose.
Yeah, I believe that the rate of thrombosis in these stents is higher in patients who had a completely occluded vein that was that, or thrombosed vein that was that, but with scar tissue that was then opened, as opposed to the person who has compression of the vein by the overlying artery. That definitely makes a difference, and we do treat those patients differently with blood thinners after the time that the stent is placed. Excuse me. One other question, Debbie, I'm going to give this one to you. We had talked a little bit about doing a follow-up ultrasound. Let's take the patient that has had a procedure done, a superficial venous procedure done, and now they've come back and they've got a blood clot near that junction, do we need to treat those patients or not?
So it kind of depends on provider. So depending upon where it's located, some providers will treat them with just a baby aspirin or a regular aspirin if they're not on anything. If it's sneaking pretty close to the deep system, then they may be a little bit more aggressive and do some anticoagulation just to be on the safe side. As far as follow-up, we're going to see those patients back in a week and re-ultrasound them to make sure there's no progression of that phlebitis that's taken place in there after a procedure.
Thank you for that. And then what about in the patient that's developed the superficial phlebitis that's kind of crawling up the leg and it has nothing to do with any procedure? How often, Dr. Raible, would you want to see that patient back and scanned?
So typically, if we're treating them with conservative measures, NSAIDs, compression, elevation, and their symptoms are getting better, I'll see them back in 6 weeks to 3 months for a follow-up scan. And we educate all of our patients, if your symptoms are worsening, come back and see us right away, and we'll scan you then. But if you're getting better and your symptoms have improved, usually I'll go, out to 3 months even.
That's great. Thank you. One other quick thing that I want to mention before we close, patients who are pregnant can be at a little bit higher risk of DVT than those patients who are not. How do we treat patients who are pregnant with a DVT? Dr. Raible, that's a question for you.
Maybe a question better for a pharmacist, but so Lovenox, I believe, is the main therapy nowadays. The newer medications, Xarelto, Eliquis, are contraindicated in pregnancy, as is warfarin, I believe. So Lovenox is kind of the mainstay.
Yes. So those patients who are either at risk, either during their pregnancy, they develop a blood clot, or right before they deliver or right after, if they have a clot, those patients can be safely treated with anticoagulation. It's just the one that we have is the Lovenox. But I really want to thank everybody, the amazing panel that I have the honor and the privilege to work with, as well as VLU for putting this very interesting program on. And we're going to repeat the same discussion in Spanish. So keep your eyes out and your ears open as to the date for that. Dr. Gloria Salazar, who couldn't be with us tonight, she is the lead moderator for that. But it was really great to have all of you present, the speakers as well as the participants. And behind the scenes you don't see, we have Victor Canada, who is just the wizard at technology. So thank you for that as well. I hope everybody has a great night.
Thank you.
Thank you, everyone.
Thank you.